Good afternoon, everyone. I want to thank you so much for joining us for today's event, Beyond the Buzz, Defining Food as Medicine. My name is Charles Platkin, and I'm the founder and director of the Center for Food as Medicine and Longevity. The Center for Food as Medicine and Longevity is an international nonprofit dedicated to bridging the gap between traditional medicine and the use of food as medicine in the prevention, treatment, and management of disease. We work to increase access to these interventions, advance research, and create a more equitable food system that improves health outcomes. We're incredibly fortunate today to have several leading experts joining us to explore the true meaning of food as medicine. What is it? What isn't it? And what it will take to move it beyond marketing slogans. So I want to introduce everybody. Our distinguished panelists include Sarah Mastrorocco. She's the Vice President and General Manager of Instacart Health. There's a little joke about the name there. I didn't get it right again. Natasha Pernicka, the co-founder and executive director of the Alliance for Food for a Hunger-Free New York, executive director for the Food Pantries for the Capital District, and Dorella Walters, MPA, the Chief Business Development Officer of God's Love We Deliver. And I'm honored to be joined in moderating today's discussion by Alexina Cather, a close friend and colleague. She's a director of policy and special progress at Wellness in the Schools, and also on the advisory boards of the Hunter College New York City Food Policy Center and the Center for Food as Medicine and Longevity. We only have an hour, so I want to jump right into the questions. And I'm sorry if I botched anybody's name right there. That's a longer introduction than I usually read. So let's start with the term food as medicine. Right now it's being used to describe, everything from food banks to nutrition apps to corporate wellness programs. And I just wonder, has the term been watered down? And what should actually qualify as food as medicine? How do you define it in the context of public health and nutrition? And I think that the issue here comes from, even places that were already traditionally providing food to individuals, whether it be a food pantry, feeding programs all around the country. They're using the term food as medicine now. And I just wonder, is it being misused? In my opinion, it is slightly being misused. So I wanted to hear what you guys think. I'll open it up to any of the panelists.
Being from a food pantry organization who may or may not be misusing the term, we really take our framework from food as medicine. I love Tufts' food as medicine pyramid. So when you're looking at the food as medicine pyramid, you're including all of the different kinds of nutrition services and programs from a prevention and public health level at the bottom. So the public health level prevention programs like SNAP, WIC, food pantries, those are more about food insecurity, making people have food. And as you go up the pyramid, the programs or interventions become more and more scaled towards actually treating chronic conditions and illnesses. And Dorella's work, I think, is important in the definition of food as medicine as far as a specifically tailored food that's created by a registered dietetic nutritionist. And I would also include having nutrition therapy along with the food. So I don't think it's misusing the word. I think we need to look at it as a spectrum of services that have different uses. And I also think not all of the services should be paid for by healthcare. I think there's a lot of different ways to get to that end point. I'll stop there. Thanks.
Thank you. And Natasha, just to be clear, you really, in the last two years, I think you've been so educated in what food as medicine is. You're really so involved in that space, and you've really taken it on to be a new meeting. So just hats off to you and everything that you do. So.
Well, thanks. I mean, from a coalition of food pantries, we got into this work through New York's 1115 waiver DSRIP, and we felt that food pantries would be a really great access point and wanted to focus on improving the nutritional quality of the food in the food pantry system and couple it with registered dietetic nutrition therapy services. So that's where we got involved.
Right. And I think that, just to talk about it specifically, I think that you took it to a different level that it's being used at around the country. And I think your model is much different than what I'm talking about. I just think that, I guess I'm working on this book project, and with my editor, I constantly say this concept. I say, well, it's very important to note that just because if you feed somebody that's eating unhealthy food, healthy food for 6 weeks, and they were eating unhealthy food, garbage food for their whole life, you're going to change their numbers, but that may not necessarily be considered food as medicine or food as medicine, right? Because all they're doing is creating healthy eating, and that's not necessarily the way the terminology it should be transcribed. And that's, I guess, my thought on it. I want to hear dialogue around that.
And yeah, I'd love to jump in from
Yeah, of
an
course.
thank you again for having me. For those that don't know, Instacart is active in the nutrition space, healthcare space. We would argue food is medicine space, but in your question, and what I would think is, I'm not here to decide terms. We're coming in as a consumer app and technology company, and when we entered the space, though, in late 2022, we were very deliberate about making sure that Instacart Health wasn't a vanity. It wasn't like a vanity plate. It really was something that we're providing. And for us, I can say when we think about food as medicine, Instacart Health has three pillars. The first is access, like sustainable access, financial and physical access to food. Once you have that food, how do you make healthy choices easier? And when we combine those two things, we create programs that we do call food as medicine. And that is, a lot of 1115 or in lieu of service interventions, we believe we fit quite well in. And we have a voucher program that we call Fresh Funds that are customizable that can be plugged in with medical nutrition therapy, as part of an incentive or award or therapy, or can work separately. And for example, we just announced yesterday, we had a lot of announcements. We are registered as an atypical provider in Michigan in their CHAMP system. We're able to deliver healthy food packs and produce prescriptions through our voucher program. So it's giving people and kind of Charles, kind of jumping onto what you said on like, it's not just do we change, but we think it's about developing lasting, sustainable behavior, helping the whole food system. So, for example, in Michigan, if there's a produce prescription program, you can get a healthy food voucher that works on Instacart. You can choose the local store that you want it delivered from or curbside picked up from, and you can go on Instacart and get more advice on what actually should I be buying. We have a partnership with the American Diabetes Association that gives you food access. The Fresh Funds will be tagged so you have items. So for us, again, I can't speak to like what should food as medicine be, but I feel strongly that Instacart has a role to play in the equation, and we want to work with providers and health plans and governments to figure out like, can we help you deliver sustainable, like either coupled with therapy or separately, deliver sustainable solutions that can help people eat better, feel better, and drive health outcomes.
That's great. Thank you for that, Sarah. And it's interesting because Alexina and I were in the very early days with Fresh Direct, and I'm happy to say something negative about them. We brought this whole thing up to them to basically create this kind of program in NYCHA housing in New York City, and they strung us along, created press releases, and then never delivered on that. We had a whole program developed and designed. They wouldn't have to pay for anything. And so it really was, amazing that what you did and how you're creating this and pulling into the space in such a nice way. I guess, with God's love, we deliver. I think that this is really, just so you know, this is how I got into this entire space from Karen Pearl. She had emailed right before the year before I came director. I was a faculty advisor and member and founder of the New York City Food Policy Center. She sends an email about food as medicine. I'd never heard of the concept before. This is like in 2015. And and the director then just didn't even look at it. And then I was sort of scouring through my emails when I took over and saw that, and thus planned the first food as medicine event for the New York City Food Policy Center. And I have to tell you, it was unbelievable, the overwhelming response that we got. It was incredible. And we decided at that moment, after that first event, that we're going to continue in this process and looking at this and examining it. And one of the things that has come up over the last, and why I started the Center for Food as Medicine and Longevity, was because I thought there needed to be scientific research behind foods that are being given out. So this goes to you. At God's Love We Deliver, you've been delivering these meals, for AIDS, for cancer. How are you looking at it in terms of what to provide, and how do you know that it's medically correct, and how does that work?
Hey, Charles. So God's Love is a part of a Food is Medicine coalition that works closely with you all and with Tufts and all of the other organizations mentioned earlier. And we were just down in DC. So the food is chosen by a registered dietitian nutritionist. That's the lens that everything is kind of planned and determined. Everything should be sustainable and easily prepared. It should be nutritious. It shouldn't be complex in terms of what the actual customer or member or client will eventually be receiving, right? We want to make sure that everything looks fresh and is appetizing to the individual so that they are motivated to eat. So tying back to something you were referencing very early on, it's it's not just that a person changes the way they eat, it is the process of helping them learn that there are also other ways that they could be accessing food for themselves and their families. So we understand that medically tailored meals, as Natasha was saying earlier, is for a smaller portion of the population. Chronic illness is that's what we're trying to solve for or address. So there are certain diagnoses like renal failure when someone's on dialysis that they have to have a particular type of dietetic regimen that not everyone can provide, but that's what we concentrated on being able to provide so that people could be successful while they were experiencing that particular health-related intervention, whether it be dialysis, whether it be chemotherapy and radiation, right? So we want to make sure that food is appealing to the individual. It should be, that's the intention, culturally appropriate for them so that they are motivated to eat. We want people to eat nutritious food while they're taking these medications. We want them to take those medications as prescribed. And we've found that that's a way to help them do that.
I'm curious. Sorry, real quick, just a piggyback on that, and thank you, Dorella. Are you finding that with the term food or phrase food as medicine being more ubiquitous, are you finding that I use the term easier loosely because I know your work is not easy, but easier to get buy-in, to find funding, or is it more challenging now?
I would say we're probably in a middle lane. I think there are different voices that are trying to interpret the phrase. And I would attribute that we should all maybe concentrate on the Aspen Institute's kind of categorization. It is all of the services, as Natasha was describing, within that pyramid. It is looking at a person's overall health, even if it is in the prevention landscape, to make sure that people nationally have access to proper nutrition. The concept of food deserts, especially if someone's going through a serious or chronic illness, it's like a double whammy, right? Terrible situation. So the concept of food is and food as medicine is trying to help the population as a whole and healthcare specifically to really understand if you have someone who has been in the hospital and you don't ask them their food insecurity questions for when they go back into the community, then you are doing a disservice to that individual and they will come back because they're not managing that illness in any different way. But if healthcare recognizes this phrasing of food is food as medicine, then it becomes, oh my gosh, I need to make sure that you have proper nutrition when you are out in the community so that then you'll be engaged in clinical care and we'll be able to both work together to help get you into whatever improved health state that you're trying to work towards.
Wow.
That is one of the, I was just wanted to talk to that after getting people connected to the community food programs is one of the biggest gaps, but it's also one of the biggest opportunities that states have through 1115 waivers is building infrastructure for doctors and hospital systems to make referrals to community food programs. There is one of the things that really motivated me when we were originally learning about this is just the number of people really struggling with malnourishment. And Health Affairs had an article years ago that was documenting the number of people struggling with malnourishment, the increased rates of returning to hospital, and so many other things that could be prevented through having enough quality and quantity of healthy food.
But I would ask you again, just because you brought that up, let me go back to God's Love We Deliver and what they're doing. And, when you say you have a registered dietitian's lens, and I understand, I taught RDs, future RDs and they became RDs. And I guess I wonder, I'm struggling right now because we have 17 PhDs working on doing research on 40 different disease states. And there were deliverables was supposed to be done by January 5th. Okay. So now we're March 19th. Those deliverables still haven't arrived. So you have these 17 PhDs working on these 40 lit reviews on different disease states and how food can impact that treating or prevention. So again, that literature is not wide open. And I just think that and you really opened my eyes, Dorella, yeah, Dorella, you really opened my eyes, because until Natasha just spoke about this, I was very skewed, because I understand what you're saying now. And you say you're in the middle lane, and when Natasha's talking about how she's developing this and how it is important for government funding of these programs and things like that, I guess now I understand. But we still need the base evidence, right? And I still think we're missing that. I don't think I'm going to fill that gap because I have no funding. I'm funding it myself. But I think that we're onto something. Right.
We are. And I think so in terms of research, so out in the ether of our country, we have different kinds of research that has occurred. One of the things that we need to consider is that some of that research has only provided one meal a day to individuals, and their outcomes were a certain outcome, whereas people eat 3 times a day, snacks in between, etc. So, at least with a medically tailored meal model and some of these other interventions, you're able to at least provide enough food to be able to see both change in behavior and change in outcomes such as A1C for diabetics and in adherence to medications for people with HIV or AIDS. I do think that more research is needed. There are 2 levels of research, let's call it that. We know that insurance plans have been seeing the return on investment when they look at addressing food insecurity and malnutrition in their members, and they incorporate it into their plan of care. Like Medicare has it when people are being discharged, Medicaid programs, you see it in 1115 waivers across the country. The other thing to consider is, how do we help institutions have enough funds to create robust double-blind studies, et cetera, to be able to demonstrate what kinds of food and nutrition interventions can help an individual demonstrate more positive outcomes. And what are positive outcomes? And they're not just clinical. If you can maintain people outside of the hospital and outside of the emergency room, those are certain sets of outcomes, which are amazing. Yeah. But then when you see that they are changing behaviors in the way that they are cooking for their family, able to ambulate better, et cetera, those also. But so that's why we need everyone to participate in creating a deeper research bench, which I think is what you're saying.
So I agree with everything, except there's such a limited amount of funding, right? And when you have feeding programs that are changing their names to food as medicine programs and food as medicine programs, and they were just traditional feeding programs and food banks, I just wonder if that takes away from the research that you're talking about that's needed for evidence to show what foods and dietary supplements impact disease. And again, I feel differently about it than when I started this conversation, which is great, and kudos to you. And I think that one of the jobs that Alexina and I have is to try to advance the science, not just spit out what everybody else is spitting out, but come up with, stand on the shoulders of giants, right? Let's really try to move the discussion so that, people that walk away from this have a different understanding. And I think that the fact that you've already changed my mind, I think is a big thing. And that the broader perspective of food as medicine is important. But there needs to be that evidence-based work that needs to be done. And that means when you call out that someone has Crohn's or cancer, or different types of cancer, or they have AIDS or whatever it might be, there needs to be a significant bundle and package of research that supports what foods should be going into those dietary meals, or not prescription produce programs, but in those meal kits, right? And that's all I think I'm thinking about. Alexina, do you have anything? And Natasha, I think you have a good perspective on this because you've been toiling in this and seeing what others are doing and what you're doing, and there's a big, vast difference.
I have a follow-up question to that. There's a lot of constraints, lack of research, funding, meeting difficult populations. I'm wondering what you all think are partnership models, like between, public-private entities. Sarah, I think you could speak to this, especially coming out of the White House conference, but where is there an opportunity now to not duplicate efforts, but to see where people can support between nonprofits, corporations, and government entities to further advance?
Happy to speak to a little bit, but I agree. It's public, private, and just partnership period has to happen, right? It can't be. And I think everybody's coming to the table. No one can do it all together. Instacart has been very open that we're a platform. I'm not a doctor, right? I'm not a dietitian, but we have a very powerful platform that reaches 95% of food deserts, 98% of households in the US with same-day fresh delivery. And we've created technology that you can run research off of, right? Instead of us being the sole provider of research. And that's resonated just last week. We announced a partnership with Rockefeller and AHA and the Veterans Affairs. And to speak about research, I agree. And I think, Charles, you're saying a lot about like the exact food, but I also think that there's a lot of evidence for medically supportive food and groceries. Same Dorella is talking about like you're eating a meal, but guess what? There's a bunch of snacks. So how do we make sure that medically supportive food can be part of the equation? Okay, I thought you were shaking your head no at me. I'm like,
no. So a little bit because it's what you're doing. I think really what you're doing, and it's not because I use Instacart and like it, but I think what you're doing is really magical.
Okay.
And it's just it has the potential and capacity to make so much change in society. And I really because you have such wide usage, the fact that they took it upon themselves to see this as an opportunity, and you're a public company, and you're trying to move the needle in social dynamics, and so I think that's amazing. I just a little bit. Could you just talk a little bit more about exactly what Instacart's doing, and then
no, I'm glad
we have a large audience here.
I'm glad you brought it up. So
we have a worldwide.
I'll talk about Instacart, and like our Instacart Health's mission is we want to make. I'll talk about Instacart. I'll talk a little bit more about the research too, because I think that's important. But that we're very transparent. That Instacart's job is to like make grocery shopping effortless on any budget for anyone. But Health's mission is to do it to make it healthy. And we're doing this as part of a for-profit public company. But it's my job to make sure that if we are serving patients' needs of all income levels, that we do a great job at it, and we want them to keep ordering on Instacart. We have a huge base of EBT SNAP customers that have been an EBT SNAP recipient or still are, and they're shopping us because we're saving for time and transportation. We're solving for mobility issues, stigma, and budgeting. I may use Instacart very different than you may use Instacart, right? And like there are ways to like really save time and money. And that was our basis of Instacart Health. It was like, oh, great, we're onto something here. And the programs we run off of Instacart use basically wraparound services. Instacart Health, for example, I talked about the Veteran Affairs. They get $100 a month for 12 months. We work with Kaiser Permanente on a huge randomized controlled trial that's going on right now. And that's, again, for people on Medicaid with diet-related chronic disease, they're getting $100 of medically supportive food and 4 wave deliveries a month. And we're tracking that. And to your point, what happens to their health outcomes? What happens to their use of healthcare? Positive or negative. So that's one example of how it's being used. And that they get a voucher. They come to Instacart, what we call Fresh Funds. They identify themselves. So like it's a consumer relationship. They're identifying, yes, I want to be part of this program. And I agree to share everything I bought back with Kaiser Permanente as part of that program. So they have exactly what they bought, how much they used it. And then Kaiser Permanente can then use that to study health outcomes, and Instacart is the vessel. But that person, the power of that is also that person can add their SNAP dollars, add their own money, and complete their whole shop. I always say, like, you also need toilet paper, right? So like, how can we help you solve the whole shop and really be part of your life sustainably? And the Kaiser is just one example. The other one research I want to say, and we're continuing to do that with Rockefeller and VA, and there's like more than 10 other studies with major research universities that Instacart comes to the table as a consumer expert and a technology expert, not the food as a medicine expert. So I think that's really important for us. We know our role. Hopefully in the next year or two, we're going to see a lot of positive outcomes and just research that'll help inform medically supported food. The last thing, and then before I give back, apologies for talking too much, but with medical nutrition therapy, we had a partnership with Food Smart over the last several years. They're a medical nutrition therapy platform. They actually have had 18,000 patients that they tracked using either the medical nutrition therapy with Instacart, Fresh Funds, Instacart incentives or not. And the ones, of course, everybody did better, right, with medical nutrition therapy. But it's really cool to see people that had the food or not had significantly better outcome. Like 50% of people with diabetes who combined it with telenutrition with Fresh Funds saw a 0.5 reduction in A1Cs. We had people that sustained 5% weight loss, 50% more sustained it when they had the Fresh Fund. So there's a report there. It's all public, but we were excited to see that like just that scale and to show that like coupling nutrition therapy with food is so much more powerful, we think, and engaging like than just food. I'm sorry, than just medical nutrition therapy alone.
That's fantastic. I have one question for you. Have you, and excuse me if I'm ignorant here, will you ever plan on basically packaging, like let's say with a provider, not a healthcare provider, but one of your providers, like a diabetic meal, like for sale, or a diabetic meal plan, like one of the meal delivery programs like Factor or things like that.
It's a great question. Today we have 85,000 stores on our platform, 1,500 different retailers. It is mostly local retailers. You can go in off the shelf and order something. So it's your local Kroger, Aldi.
No, I'm sure there's a way to wrap around that. That's what I was thinking because I live in New York and Miami, so so I'm using Instacart in different places. There are different providers, but one of the things you do across platform is take the things that people buy, naturally, and you can cross pollinate that. But I'm just wondering if that's ever something that you've been considering.
We're always open. I think our goal is to be like the one-stop shop for people. Right now, we're known for like same day, I want it right now. But I think that ship to you or having meals on the platform is not out of the question at all.
Yeah, or coming up with ways with your largest supermarket providers and packaging meal kits. I know Fresh Market does that in Miami. It's incredible. They have incredible meal kits. They're just really phenomenal. Natasha, so I had a question for you, but I forgot it. But I wanted to hear more about all the things you're doing around food as medicine specifically, because you have been running this program, a food as medicine program in New York State for a while now.
Sure. Well, I wanted to go back to a little bit what Dorella was mentioning earlier with the Aspen Institute and the definitions of food as medicine programs. I think that is one of the things we all need to rally around is coming up with standardized terms. And, how much food? Is it 1 meal? Is it 3 meals? Is it, do you get 4 days worth of food or 7 days worth of food? And even over time, these things do need to be tailored per a person's own experience and resources as well. But I think that's one of the reasons that we started the New York State Food as Medicine Coalition, because in our experience with the District 1115 waiver as a coalition of 70 food pantries, we had our model that we developed, but across the state, a lot of different organizations were doing food as medicine differently. And we really believe strongly that in order for things to become a medical intervention that is paid for by healthcare, it needs to be standardized. And so I think you can think of this movement as kind of in baby steps, like we're in the younger phase of it where people are excited about it. Medically tailored meals has been around the longest. So there's the most research to show that the specific meals work. But when you're looking at veggie and produce prescription programs, or the 1115 waivers have pantry stocking. Well, pantry stocking, anybody could be getting any kind of food with that. And I believe that that was kind of a lost opportunity in the new waiver. I think we could have done a better job of defining the nutrition standards for some of the grocery models. But I believe it's also an opportunity for us to continue with lessons learned and as advocacy groups and those of us who are able to participate in research, bring it to the table so that we can all be working together to move it forward. And so when you're talking about partnerships between government, private, nonprofit, when we participated as a nonprofit in the government-funded 1115 waiver, our experience with that showed that we really need to be working with all of the stakeholders in this group so that the programs work for everybody involved. So we now have hundreds of people who participate in the New York State Food as Medicine Coalition from state government, from private companies that have different, opportunities. We have people in the supply chain, people who will sell you boxes tailored, for groceries for different things. We have people in the produce prescription world and food banks. When you're talking about food banks earlier, a lot of food banks that are talking about food as medicine programs, it doesn't mean their entire distribution is food as medicine. They typically have a program that's tailored and very specific, and they might have a hospital partner that they're working with in a very specific group of people. So I think it's important for us to standardize the models, and the more we learn about what works through research, then we can all move towards what's working. That's my thought.
I wanted to hear from all four of you, including Alexina. What's your biggest bugaboo about the term about food as medicine and working in this space? What's the biggest issue that you'd like to see resolved, if any? Natasha?
I saw Dorella come. Go for it, Dorella.
Right.
I recognize that Instacart, everybody was down in DC probably last week. I think a national recognition and folding in of food is and food as medicine interventions across all levels of care is the thing to strive for. The MTM bill.
What does that mean, folding in? To talk about it.
So the Centers for Medicaid and Medicare Services recognizing food and nutrition services across a spectrum, depending on an individual's health acuity as well as ambulation capabilities, is a transformative way to really look at every level or age in our country and address food insecurity and malnutrition. Right now, you only have a solid nationally funded food program for the older population, which is the AAOA, right? And then you have SNAP, and then you might have child lunches, depending on where you live in the country. So really the next phase of transformative, let's say healthcare or transformative existence in our country as it relates to food and nutrition is really recognizing that everyone lives on a spectrum as it relates to their food and insecurity abilities to address it. When someone in the middle of the country in a food desert gets cancer and is on chemo and radiation and they're under the age of 60, they are out of the game nutritionally. They merit, right, having some kind of an intervention that supports them at that moment of time, and their clinician should know it. Yeah.
Yeah, that's what we hope that Sarah's Instacart can come in and provide some of those things, combined with the research that's out there. That's great. That's really wonderful. Just great thinking.
To speak to the Instacart, though, I mean, in our work with the pantries, transportation barriers were significant. So for most of the individuals and families that received healthy food pantry boxes from our organization, almost all of them had to be home delivered. And home delivery is challenging for nonprofits to have the staffing and vehicles to operate at a capacity where anybody who needs it can access it. And I think for me, I would want to see investments in food as medicine interventions so that anyone who needs it has access to it. Like any prescription, if you have a mental health, if you have depression, and you need to get a prescription for that, anybody can get that. I feel like nutritious food should be as easy to access as a prescription. And until we get to a point where we have the infrastructure and the ability to do that, like we will continue pushing on the movement forward. It is shameful in a country that has such wealth as ours that the significant number of people don't have the resources for access to healthy food. And, this week I'm taking the SNAP challenge, FRAC SNAP challenge, where you live off of the average SNAP benefit of $6 per day per person for food. And, I have healthy food, but I don't have enough food. I'm hungry. And so when we look at policy from a federal level, we need to make sure like USDA and Farm Bill policies are lined up with supporting investment in what is called specialty crops. Specialty crops is fruits and vegetables. That's the healthy food we need. So much of the government spend goes to soy, wheat, and corn, which goes into manufactured food, which goes into unhealthy food, which contributes to chronic illness. So if we really cared about reducing healthcare costs and providing healthy food for our population, we need to be investing money in specialty crops, which are fruits and vegetables. And we also need to make sure people have access to it. This isn't the country that has a great transportation system. So Instacart is one of these incredibly valuable resources that helps get food to where it needs to go. And I think the more partnerships between government funding and private organizations like Instacart and nonprofits who know how to meet community members where they're at and do it in a way that's culturally appropriate and responsive, it's a win-win. It's just trying to keep everybody focused on what's the end game here. And we easily talk about, well, save healthcare dollars. Medicaid's expensive. Can you imagine if everybody had healthy food with a registered dietetic nutritionist to work with them, we would be in a completely different place as we are today.
Yeah, well said. Thank you.
Thank you, Natasha, for the confidence, the vote of confidence on Instacart too. I appreciate that. I think what I would add would be that, recognizing that it isn't just the food, it's how you get the food that's important too. And I think that's been a conversation for us when we talk, especially Medicaid and Medicare Advantage, supplemental benefits. There's money out there for food, but delivery of that food is often critical for people to get access to great quality produce, right? And things. So I think I'm encouraged by what everyone's saying. And I'd also add I'm encouraged by the momentum that food is medicine and just really what people are paying attention to. How do we make sure America pays attention to what they eat? Not just for people, not just financial access, but really how do we help make healthy choices easier, which I think is a public health opportunity as well. We partnered with the American Diabetes Association just yesterday and have a page on the diabetes plate, which I honestly hadn't heard of before. And most Americans are at risk for diabetes. So I think, we talk about food as medicine, and I don't want to derail us here, but I do think just awareness of how you feed your family and what is healthy is also confusing. Just admitting, what anybody is putting on the table is confusing to figure out how do I make healthy choices for my family. So I think it's an opportunity for us in partnership, right, with everyone to make sure people feel empowered to make the right choices with the money that they have.
I love what all of you said. I think when I'm thinking about what gets the thorn in my side. Sorry, did I cut you off, Sarah? Were you done? Okay. Is that, we continue to place the onus on the individual rather than addressing it as a systemic issue. And I think that's where if we approach food as medicine from a systems perspective, we would have the most change. But I love hearing what all you are saying in terms of the partnership. I think it should be more on the government to, fund these programs and stuff. But like you said, they don't have the transportation system. They're not creating that. So there are opportunities to really further it. And my next question would be, how do we ensure that food as medicine isn't just another passing trend in public health? What do you think it will take to make, and it's not passing trend, God's love we deliver. A lot of people have been doing this work for a very long time, but it does feel like there is, like you said, Sarah, there's more attention being paid to it, which is a good thing. But how do we ensure it's not just a passing trend? What will it take for it to actually, like, food-based interventions to become a legitimate part of healthcare pervasively across the United States, not just.
Let me add something before you finish answer. You done, Alexina?
Now I am. Yes.
Okay, sorry. No, I just wanted to add that, every week I do a news and research digest, which goes out to 185,000 people. And, so I'm constantly looking and searching for certain key terms. And I've noticed over the last 3 years that, certainly in press releases, because those are Googleable. And I think that I've noticed that this is why this whole program came about, because I started noticing a trend where it used to be I'd pick up maybe 3 articles or 4 articles. Now there's hundreds, 3 to hundreds. So that's where this whole idea of, it being a passing trend, and it seems like it's a funding magnet. And that's why people are using that terminology. But I don't really know. So that's another question I want to tap onto that. So let's, with Alexina's question.
In terms of Alexina's question, I think I'm going to take it twofold. So I think it's both the individual and the infrastructure that needs to move. The infrastructure has to exist for individuals to have and leverage their own agency to determine how they're going to bring food and nutrition into their home. Let's call it that. And I think that's a funny spot because how do you scale that, right? It's got its nuances based on the region that people live in, et cetera. But at its most basic, looking at national opportunities, which is why we were all on the Hill. The Food is Medicine Coalition was there, Tufts was there, the Center for Health Law and Policy. Everybody was down on the Hill talking about the MTM bill, which is a way to help our elected officials create an opportunity to pilot across the 50 states. 40 hospitals would be partnering with Food is Medicine organizations to be able to really look at implementing a Food is Medicine model, right? To then justify, quote unquote, implementing a full coverage concept for food as medicine, right? To be in existence for the country. I do think, given this new political landscape, there's lots of things changing in the landscape, but there are pathways where there is bipartisan support that recognizes food insecurity has to be addressed. So I do think it's about talking to elected officials. It is talking to universities such as yourselves across the country. Everyone needs to be embedding the value of addressing food and nutrition. And that includes from farmers all the way to the person that, is too frail, alone by themselves, and someone else is managing their life, quote unquote, whether it be in a hospice or in, end of life care in the home. All of that is important and valuable and should have standards attributed to it. So we're talking about all of these potential, organizations that can give expert advice to that. What should that look like? Tying back to what Natasha was saying. Is it about lunch and dinner for 5 days a week? Is it breakfast, lunch, and dinner for the 7 days a week? Because that's what proper nutrition is supposed to look like. But we need enough studies to help support that. But I do think that that's a path. And I don't know when we'll finally get there, Alexina, but I think we're going to get there really soon. Fingers crossed. That's my hope.
Right. If you could wave a magic wand, Dorella, what would you want? What would it look like?
Magic wand would have states being able to make food and nutrition decisions with enough funding to create transformative change for the population.
What does that look like?
I think it's the elimination of food deserts. I think it's the support of farmers to making sure that farmers are working with CBOs as well as for-profit companies to be able to have solid pipelines of nutritious food that is as close to its normal existence, right, for people to be consuming.
Just my battery was, I didn't know my computer was unplugged. So just to be clear, would you say that, connectivity is the most important, connecting all the moving parts? Is that something that you would think is very
connecting critical? The moving parts is what the White House conference was going to start to do. I'm not going to say that it could achieve that, but I think that was a first step, right? Because then if you start to bring in all levels, right, of leadership and expertise, then that's where you can move the needle, I think. But, looking at my colleagues on the panel, because I know Natasha and others have added pieces there.
Yeah, well, I was just going to speak to, at first Charles was saying, everybody's jumping on the food as medicine train, right? And kind of as it's a negative, but I think it's a positive because
I did see it as negative, but you've sort of changed my viewpoint, which is great.
Well, but to the point of that, it's like you now have all of these other groups that are interested in it and are advocating. We weren't involved in this 10 years ago. In fact, when I started at the food pantries for the Capital District almost 14 years ago, most pantries in our coalition were not providing fresh produce. Now, 14 years later, almost all pantries are providing fresh produce. And we implemented a healthy pantry initiative a couple years ago where we're looking at health from a lot of different perspectives. My big concern is that, when I was back in college, my grandparents used to get a food box from the food bank, and it was very much the USDA food, the free, the government cheese, the canned chicken. And it was you get what you get. And, my grandma wouldn't eat all of it. She's like, I don't know what to do with this. And we have made so much progress over the past couple of decades of moving beyond you get what you get to adding dignity to the charitable food system. There's still a long way to go, but I think I'm afraid for that being at risk, but I'm hoping that we'll be able to stay strong. But that connectivity that you were talking about and coming together with private and government and working together on ensuring that nutrition security is one of our primary focuses for community health. And you see it from schools. School breakfast and lunch is critically important. You see it from the WIC program, making sure that pregnant mothers and infants have adequate nutrition. I mean, there was a point, we run a food access referral line here. There was a point where a man had been laid off and he came into the office to try. Well, he came into the office and he said, well, we said, we're not a food pantry, but we can refer to you a food pantry. And he said, I'm living off of hot dogs, but I need formula for my child. I can't afford formula. And we are at a point where 60% of Americans are living paycheck to paycheck. And we don't have the stability of an economy that can support people in that food security, that nutrition security. So I think by having more groups, private industry, government, nonprofits working together, along with researchers and academic institutions, we bring all of those pieces and you want the facts? Here's the facts. You want the numbers? Here's the numbers. We have stories. In fact, I asked some of my team members for a story that I'd like to share because it just, you're talking about, is it a systemic or an individual? And my team was letting me know there was a woman referred to our program. She has type 2 diabetes and hypertension and high cholesterol. So her goal while working with our program was to get her blood sugar down. And so they were also experiencing low blood sugars, indicating poor blood sugar management, right? So their eating pattern was irregular based on what they had available. But during our program, they worked with a nutrition therapy. They got consistent access to healthy food. And it's interesting, the person said, at first they didn't like the food they were getting, right? And Dorella, you were talking about we want people to eat the food. But I think having that nutrition therapist encourage them. So at first they didn't like the food. But the person said now after 6 months of eating this food, they crave it and it's what they prefer at this point. And so I think, you have to have that change management and that support to help people get to a place where it's making a personal difference in their life. Anyway, that's all.
Charles, you're muted.
Yes, I wanted to say yes.
I lost my computer for a second. That's all. Sorry. So Natasha, one of the things I think is really important is that what you've done, in New York State is very unique and and very unusual. You're pulling together all those resources, academicians, farm, everybody. And that's, I guess it's a little harder to do for the whole country, but you're doing such an incredible job. And it's important that you try to share everything, which I really appreciate. That how you do it and what you do. You really try to share, and when this is, hopefully we'll see a whole model that we can share with the whole country soon. So which is great. Alexina, you had another question?
Yeah, I have a question for Sarah about, there's a lot of companies, Instacart Health certainly seems to be, in my personal opinion, the leading trusted company in terms of doing food as medicine initiatives. But we see a lot of companies now using that food as medicine label to market their initiatives.
Like produce. Sorry. I don't get funded by anybody, so I can say whatever I want.
How do you at Instacart Health work to ensure that your work goes beyond that buzzword to create real impact and measurable health outcomes?
Yeah, and it's great. Apologies if my Wi-Fi is unstable. I'm not sure why, just only because I'm on this call. But I think for us, I think when we talk about food as medicine, I think it's really important for us when we come to health plans and providers and community-based organizations, that we define our role as a platform, right, and a technology provider, and then listen. We do a lot of listening, right? Like a lot of listening and then figuring out in a consultative way where we can fit in or not fit in. And I think from a food as medicine perspective, that is, we see the call to action for research. So that's why we have 10 plus research projects that we're supporting directly via partnerships or infrastructure as part of Rockefeller and American Heart Association. And then I think people have brought it up here, but 1115 waivers and in lieu of services, really doing our research on where do we belong here, right? And can we fully administer a produce prescription program via vouchers or a healthy food packs or a medically supportive food? It's called different things in different states and for better or worse. But I think when we think about Instacart Health, we also are more of a B2B brand. Instacart Health is a brand for healthcare. Instacart is the consumer brand, right? So I think knowing our role there, that doesn't mean we don't learn and develop tools. I think another good example yesterday, so there's a lot of fresh things we announced yesterday, a lot of things on the platform. Like a consumer can come on and change their profile to, I want to see more low sugar, right? Or I want to see more gluten-free. And that to me is like, that's a great asset for healthcare organizations want to leverage, but it's also just great for America, right? Like if they want to come on and use our platform. And I say, I'm always here to say like, yes, you can get it delivered or curbside pickup, or you can just use it as a shopping list or use it as research. So for us, like again, we did not even, I worked on Instacart Health for a year before we called it Instacart Health, right? And that's how conservative we are. And we want to come with partners and with data. We launched with data. We worked with No Kid Hungry for a year prior and showed that just subsidizing delivery and letting people use SNAP dollars in light education, that families grew their produce purchasing by $7 more per week, almost $7 more per week, and kept the same budget. So like those are the kind of things we're like, oh, we're onto something here. How do we continue to grow and really position ourselves as part of the ecosystem, which I've heard a lot on this call. How are we part of the ecosystem? And kind of related back to your magic wand question. When I think about it, I think Natasha, you said it. We want food to be as easy to prescribe as medicine is traditionally. And what can Instacart's role be playing in that? When we talk to healthcare providers, people want to ask if people are nutrition insecure or food insecure, but if they don't have anything to offer, it is really hard for that healthcare provider to ask someone that. And that's insight to me, right? So I think we can be like, great, let's imagine a world where you can ask that and say, well, Instacart has a free SNAP screener. In 2 minutes, you can find out if you qualify. Here's a link, right? So like maybe that's like just like baseline. I have nothing to give to this person, but I could give them that. It's like, oh, maybe this food bank offers a free program. Please go sign up here. Or, hey, you might qualify for this in lieu of services benefit. Contact your health plan and Instacart get you started. So I'm rambled a bit there, but like when I think about this world and how Instacart can play, it's a piece of the puzzle. And it's directly with health plans or with community-based organizations. And it's just hopefully, we were all, I was not, but my coworkers were in DC together to try to raise awareness and really move forward this public-private partnership.
Thank you. It's so thoughtful, really.
And I think I just want to add, earlier, the magic wand. There are 66 approved Medicaid 1115 waivers across 47 states right now. And there are others in the pipeline, right? And the reason those exist is to address the social, determinants of health, right? Or the social drivers of health. So it's clear that from a political standpoint, right? From a governmental infrastructure standpoint, there is an awareness that change has to occur. And that these perhaps pathways, waivers, in lieu of service, et cetera, are ways to really modify years of, let's say, a bureaucratic construct and a new way of thinking about food and nutrition, and by incorporating solutions to food insecurity and malnutrition. And I think that's really transformative, right, nationally. And I think it's going to be really important for all kinds of organizations to work together in different ways, because everyone provides different kinds of services depending on the communities they're serving, and how to do that in a way that's impactful, but then at the same time working with academia to really get enough research to understand what things might need to be nuanced or tweaked depending on the populations. Because just because something works for, a Latino population in South Texas doesn't mean it's the same model that you should implement, in rural, Alabama or something like that. So I just think that that's something that we should all think about, and how can we kind of all work together to make that happen?
All great information. Honestly, I have to say, I'm not an easy mind to change, but you have all changed my mind and opened my thought process in a much greater way. And I really do appreciate that. I'm being sincere. Alexina knows me. I'm very transparent, and I really did come on this, panel discussion with the thought that, that the food as medicine concept was hijacked, and really that's a very unsophisticated way of looking at it. And I like the way you're framing it in a more ecological and holistic way, which I think is very, very important and transformative. I think that, staying in the lanes is important too. And not that this is self-serving, but what we're working on here at the Center for Food as Medicine and Longevity is bridging the gaps between healthcare providers and non-traditional, what was considered complementary, but I consider it integrated, right? Medicine. And I think that what we're doing is having these researchers, just like the guides that we provided during COVID-19 for the New York City Food Policy Center. These guides were sort of everything that people needed to get food. What food pantries were still open. We updated them on a daily basis. That's what we're doing. We're taking that exact model and we're putting it towards disease and how food and dietary supplements can impact disease, right? So we have researchers looking to see what food actually impacts diabetes in the most way, or CVD, or gut health, or whatever it might be, right? And we'll have all that research and we'll update them weekly. So scouring the literature, and then it'll be free for everybody. And that's the goal. So that if, a question comes up, for God's love we deliver, of, what's the best, most evidence-based way to treat HIV with food or dietary supplements, you'll be able to go to the center, know it's academically sound, our web, site, and know that it's academically sound. And that's really what we're focusing on. But anyway, I want to really just thank you all for coming today. It was exceptional. We've done about 70 of these panels, and some of them I walk away thinking like I didn't do anything here. This was a waste of time for people that came to the audience. And this particular panel, I think, did a lot, and I think it opened up a lot of eyes to exactly what everybody's doing and leaders in this space. And I really want to thank you for that. Thanks for Alexina for everything that you do, because that I think you're incredible and you do incredible work.
Thank you.
And I think that we've spent a good hour here and made good use of what we do here. Please remember to go to foodmedcenter.org. That's foodmedcenter.org. And, subscribe to our newsletter. It's free. Every week it comes out. It has news and research that has come out that week. And it's been really valuable, and it's been seen all over the world. And I have to say that, one of the biggest moments was when Alice Waters subscribed. So I just thought that was like, I screamed to my wife, "Oh my God, Alice Waters just subscribed." So I think we have a great audience, and I thank you. And then one last thing, which is very hard for me to do, but I'm going to ask, given the light of what's going on in funding, we actually created a GoFundMe page for this disease and wellness resource guide. And we have 17 PhDs, and they're getting paid almost nothing to do these lit reviews. They're really volunteering, and we're giving them a $500 stipend to do probably 100 hours of work. So you can go to foodmedcenter.org fund now, or just go to our GoFundMe page, which is easy to find for Center for Food as Medicine. So I just want to thank everybody, and thank you guys for taking all this time. And everybody's so busy, and I know that we rescheduled this 10 different times. So thank you for your patience and helping us pull this together.
Thank you.
Very well.
Thank you.
Thank you so much.
Thank you.